Today, we're tackling a really intense topic, the complex world of severe burn management. Our mission is to unpack that whole sequence, the decisions clinicians face, balancing immediate survival against the long road to functional recovery. It really is a study in contrast. When you look at a major burn, say, 20% total body surface area or more, the body goes into burn shock almost right away. Burn shock, and that's life-threatening. It's this rapid loss of fluid from the bloodstream, with massive fluid shifts happening. So, the first challenge really is just saving the patient's life in those critical first 48 hours. But at the same time, you are thinking long-term. You are trying to minimize the long-term disability, which honestly can stretch out for years. That sets the stakes incredibly high. We are going to unpack why those standard formulas for fluids sometimes lead to significant problems. We'll look at treatments that used to be popular but are now seen as harmful, and, crucially, we'll get into the single most important rule for physical recovery down the line. Okay, let's dive in. Part 2: Acute Resuscitation Phase. Phase 1 is all about acute resuscitation. Replacing that lost fluid volume is priority number 1. There are formulas for this, like the Parkland formula. Historically, several have been used, but there isn't one perfect formula that works for everyone. And actually, despite these formulas, most seriously burned patients still end up getting over-resuscitated. Over-resuscitated? We're talking about crystalloids, right? Right, like lactated ringers. Crystalloids are basically saltwater solutions designed to replace lost water and electrolytes. The general guideline, the starting point, is about 2 to 4 milliliters of crystalloid per percent TBSA burn per kilogram of body weight over the first 24 hours. But even with that starting point, the big danger we face now, the core clinical problem, is something called fluid creep. Fluid creep sounds gradual, but it refers to this pattern of aggressive over-resuscitation. It leads to devastating systemic problems. Why is too much fluid bad? You'd think in shock, more fluid equals better perfusion. But crystalloids don't contain protein. The fluid doesn't stay in the blood vessels for long. It leaks out rapidly into tissues, causing severe edema and massive swelling. That leads to terrible complications, things like abdominal or extremity compartment syndrome. The swelling cuts off blood flow to organs and limbs, and counterintuitively, it also increases infection rates. There's even a term for when this over-resuscitation becomes deadly, the IV index. Patients who receive more than 250 milliliters of fluid per kilogram of body weight have significantly increased mortality rates. You can't just keep pouring fluid in, hoping to outrun the shock. The goal shifts. It becomes preserving vital organ function at the least physiologic cost. Clinicians track this by monitoring urine output, the most practical guide. The target is about 30 to 50 milliliters per hour. That steady urine output tells us the kidneys are getting enough blood flow. Below that, you might increase the fluid rate slightly. Other markers like serial lactate or base deficit help, but urine output remains key. Part 3: Failed therapies and what to avoid. Let's talk about treatments that were used alongside fluids but aren't anymore. High-dose ascorbic acid, HDAA, was once popular. The idea was it could reduce total fluid needs. It was hoped so, but studies didn't bear it out. HDAA failed to show improved outcomes and actually increased the risk of acute renal failure due to oxalate nephropathy, where oxalates crystallize in the kidneys and cause damage. Another problem, it interferes with point-of-care glucose testing, giving falsely high readings. If clinicians treat those false highs with insulin, they can cause real, dangerous hypoglycemia. So, it became too risky. What about hypertonic saline, using saltier fluid to pull water back into vessels? Also not recommended. Major trials compared it to standard lactated ringers, and the hypertonic group had double the mortality, 54% versus 27%. They also had higher rates of major organ failure, heart, lungs, liver, kidneys. So the risk far outweighs any potential benefit. The mainstay remains standard crystalloids like lactated ringers, carefully titrated to urine output. What about colloids, protein solutions like albumin? They're used later. In the early phase, the first 8 hours or so, capillaries are so leaky that large proteins would just escape, worsening edema. But later, colloids can serve as rescue therapy when a patient is requiring massive crystalloids and approaching that IV index danger zone. Adding a 5% albumin solution can help maintain volume with less total fluid. Part 4: Hypermetabolic flow phase. Once the patient gets through the initial critical resuscitation phase, what's called the hypodynamic ebb phase, the body shifts into a long-term hypermetabolic flow phase. This isn't a short-term stress response. The body's metabolism can skyrocket, up to 3 times normal, and remain elevated for up to 2 years after the burn. It's driven by the massive effort of healing, fighting infection, and compensating for heat loss due to damaged skin. This hypermetabolism leads to severe catabolism, the breakdown of muscle and fat. That's why nutritional support becomes absolutely critical, along with pharmacologic control. Part 5: Nutrition and Metabolic Modulation. Nutrition is a balance. The body burns fuel like crazy, but overfeeding, especially intravenously, can worsen breathing effort. So, enteral nutrition, tube feeding into the gut, is strongly preferred to keep the gut active. The diet is usually very high in carbohydrates, sometimes over 80% of total calories. Pharmacologic support includes propranolol and oxandrolone. Propranolol, a beta blocker, reduces heart rate and oxygen consumption, easing the metabolic overdrive. Oxandrolone, an anabolic steroid, helps improve nitrogen balance, reduces muscle breakdown, and supports long-term strength recovery. Tight blood glucose control is essential, ideally under 110 mg per deciliter, for better survival and wound healing. Part 6: Chemical burns. Chemical burns cause the same systemic shock, but their local damage varies by chemical. Alkalis, like lye or drain cleaner, cause liquefaction necrosis, turning tissue into a soapy liquid that allows deeper penetration. They're often more toxic. Acids cause coagulation necrosis, like cooking egg whites, forming a leathery eschar that limits further penetration. So, acid burns, while serious, are often more localized. First aid for most chemical burns: copious irrigation with water. You can't use too much. Exception: hydrofluoric acid, HF. HF acid is uniquely dangerous. The fluoride ion penetrates quickly, binding to calcium and magnesium, causing severe pain and potentially life-threatening hypocalcemia. So water flushing is only the first step. Immediate application of calcium gluconate gel is needed to neutralize the fluoride. Blood calcium and magnesium must be closely monitored and replaced as needed. Eye injuries from chemicals always require immediate and prolonged irrigation and urgent ophthalmologic consultation. Part 7: Rehabilitation and Scar Management. Now we move beyond the acute survival phase into the marathon, the long road to recovery and rehabilitation. And this doesn't start weeks later. It starts almost immediately and continues until the scar tissue fully matures, usually 12 to 18 months, sometimes longer. There's a guiding principle in burn rehab. Position of comfort is position of contraction. The body naturally wants to curl up, but that comfort leads to contractures, where skin and tissue tighten, limiting movement. Scarred skin isn't static. It contracts over hours and days. So, we constantly fight against this natural process. This involves splinting and positioning. Splinting maintains joint range of motion, often at the very end of its range, even if uncomfortable. For example, to prevent axillary armpit contractures, the arm is splinted at about 160 degrees abduction, 20 degrees horizontal abduction, and in external rotation. Exercise begins as early as possible, frequent, sustained stretches multiple times a day. Burn rehab also considers cutaneous functional units, meaning even nearby scars can restrict distant joints, so stretching must involve multiple joints at once. Scar treatment includes compression, silicone, and massage. Compression: custom pressure garments applying 20 to 40 millimeters of mercury flatten scars and limit collagen production. One ideally 23 hours per day for 12 to 18 months, for children, refitted every 3 months. Silicone: once healed, silicone sheets or gels hydrate and soften scars, reducing redness and itching. Massage: firm, frequent massage helps break collagen bundles, desensitize skin, and reduce itching. Part 8: Surgical and Reconstructive Challenges. Despite all this, some patients still need reconstructive surgery, releasing contractures, performing Z-plasties, or creating new grafts. But here's the challenge: every surgery restarts the whole scarring process. Each new incision creates a new wound, requiring the same 12 to 18-month rehabilitation all over again. This can happen multiple times, especially in children who need surgeries as they grow. It's an incredibly demanding journey. Part 9: Summary and Future Outlook. To recap, the acute phase demands lightning-fast decisions to avoid fluid creep. The rehabilitation phase demands relentless effort to fight contraction and scarring. Success depends on coordinated teamwork: surgeons, nurses, therapists, patients, and families. Despite promising advances in tissue engineering, like cell suspension sprays and future 3D bioprinting, recovery today still depends on mastering those fundamentals: proper perfusion in the first hours, relentless stretching and compression in the months that follow. An incredible field, complex, multidisciplinary, and inspiring. Part 10: Closing Reflection. One final thought to leave you with. Reconstructive surgery restarts the scarring and rehab process because it creates a new wound. So, how might future breakthroughs, maybe stem cell therapies that rebuild true skin layers, change their timeline and redefine recovery itself? Something to think about. Thank you for taking this deep dive with us.